Well, that ties beautifully into what I'm going to talk right now. I'll try to get through this quickly so we could come back to Andra before the break. And this is exactly what we're trying to look at. You know, if you look at a cross-sectional segment, one important thing that I want you to remember is there's an interosseous membrane that separates the deep peroneal artery that's back there. So as you poke through that, you're going to have a very tactile feeling as you go through it. Now, I would expand to say that this is what I would do for not only peroneal, but also the popliteal third segment, tibioperoneal trunk axis side, and peroneal axis side. And what do I mean with that? Is you got to know your anatomy, and John said it really well, you got to know your variants too. When failure of antegrade crossing, and also primary approach when long and complex disease to gain access close to the CTO cap. And also in the AT and the PT are usually prepared, but are not good vessels, then I go for this one. How? Well, angiographically guided. This is a complex case in which you could see very bad common femoral profundofemoris and osteal SFA lesions with diffuse calcification all the way down to where it seems to be there's a little popliteal, I want to go back, let me see, reverse this. Reverse one, go forward, there you go. You could see on the second image on the right, there is a reconstitution, very poor of the pop and the TP trunk, and then a posterior tibial artery. Now when we followed that PT, which would have been a good access site, it seemed like it tethered into a somewhat of a crappy vessel. So at that point, and given the fact that I like to get real close to the CTO, looking at a long complex SFA occlusion, I would rather divest myself from ankle axis and then go straight up to a very close popliteal third segment axis and or a TP trunk axis. And this just shows what Andre taught me many years ago, which is go AP and go lateral. And as I'm doing this, I'm actually putting lidocaine into the muscular planes because this could be very painful for the patient. But you could see that the calcium helps you at least align fairly closely to where that vessel is. So you actually on fluoro, you're going lateral and AP as he showed so beautifully in the last case. Now DSA, I use it once I'm about to poke because it just gives me a little reference as where it is. And a lot of times I'll just do blind pokes, as you can see on the right, knowing that that artery is just slightly a millimeter to the right side. At that point, advancement of the wire, as opposed to what Andrew was saying, I like to just go straight up with a V18 control wire, 150 in length, which gives me a lot of control, and then just make sure that it's in the right place on a lateral view. This is what it would look from the outside. The reason why the whole leg is out is I am a vascular surgeon, and my people like prepping legs because I don't know where I'm going to poke. I could poke high up, at the ankle, behind the knee, so they actually prep the entire leg as if we're going to do a bypass from the groin circumferentially all the way down. So I just cut the drape wherever I need to access, and it immediately improves the workflow. You could see the angiography through the microcatheter. Again, that's at CXI, and that is a wire working. What we're using there is a CTO wire. This is a very complex scenario given the fact that the calcification really becomes a burden to your wire crossing. Ultimately, all of these reverse carts and whatever you need to do end up with what you see here. Wire passage from below into the luminal segment, and then rewiring of that segment from the crossover and or from the antegrade segment. In this case, because of all the diffuse common femoral disease, I did go up and over. Once you have your rail and you have that patient flossed with a 300 centimeter wire, then you can pre-dilate aggressively to the point that you even rupture the adventitial space and then put a scaffold into that. That's a deployment of a supera into a very calcified segment of the artery. And as you see at the very end, a very nice recovery of an SFA all the way down with the access site still viewed on that segment. And this is a very crucial part of it, is you wire distal to your access site and then pop up a balloon, especially when your access site is in a very diseased segment of the artery, because you can very easily create a small dissection by just your access wire. So as the balloon goes up, the micro-access catheter is pulled up, and then hemostasis is accomplished. Again, thank you very much for having me, and an invitation open to visit us in Houston, Texas. It's a little, you could get sweaty down there, but it's beautiful too. Please come and visit us. Thank you.